Thank you, Gaetano. Hi, everyone. Really great to see you all here today. So, I'm Andrea Wigfield. I'm a professor at Sheffield Hallam University. I'm director of the Centre for Loneliness Studies there and also the Campaign to End Loneliness, which we moved over to Sheffield Hallam about 18 months ago. So, at the Campaign to End Loneliness, as part of the Tackling Loneliness Hub, we run this series called Translating Research into Practice, which this is one of those webinars. So, the format is usually similar. We have an academic or a researcher talking about the evidence base around the topic, and then we have somebody talking on a more practical, everyday basis in terms of how to translate that into practice. So today we've got some really excellent speakers. We've got Professor Chris Dayson, who's also at Sheffield Hallam University, who's going to be talking about social prescribing and its application in terms of loneliness services. And then we've got Jessica Duffy, who's at Leeds Older Peoples Forum, who's going to be talking on a more practical level with some sort of real life tips. Jessica unfortunately can't be here today, so she's recorded her presentation in advance. As Gaetano said, if you've got any questions, please put them in the chat, or you can raise your hand at the end. Any questions directed towards Jessica, she'll be happy to answer and respond to after the webinar, and Gaetano will send them over. So, with no further ado, I'll pass you over to Chris, and he's going to talk about social prescribing and loneliness.
Thanks, Andrea, and thanks everyone for coming in for the invitation to be here today. So, just let me get my presentation. Hopefully you can see my slides. It worked in the tests, so hopefully it's working now. What I want to do is share some thoughts with you on social prescribing and loneliness, around what's happening and what might look like in the future. And it's really a presentation in two parts. The first bit is looking at some of the broader evidence around social prescribing and loneliness, and then the second half, I want to share with you some of my own research around the role of communities within social prescribing and how I think we can potentially be doing things a little bit differently and a little bit better. Um, so, I just want to, I often start presentations about social prescribing with this slide, which is this guy is Dr. Vivek Murthy. He was the 19th and 21st Surgeon General of the United States of America, kind of like their equivalent of Chris Ritty. The reason why he was the 19th and 21st Surgeon General, not the 20th, was because you wouldn't be surprised to hear him and Trump didn't necessarily get on very well. So when Trump came into power, he moved on out of that role, and he provided this parting prescription, which is essentially his thoughts on what was needed in terms of the health of the US. And there's one quote in here that really sticks with me, as he says, as he finishes his tenure, his parting prescription and his final wish for all of us is to choose community. So what he's saying there is really shining a light on the importance of community connectedness as a key source of health for all of us. And he's saying we need to do more and promote community more in relation to health. And that's really what social prescribing is all about. Um, so what is it? I think the first thing I want to say is it's not new, but what we have seen in the past 10 years is a real explosion in policy interest. And from my perspective, I've seen that that's led to several shifts. It's gone from being something that was very bottom up and community led to something that's now very top down and system led. And alongside that, we're seeing it increasingly framed in kind of clinical terms rather than in medical terms. From my perspective, that's quite problematic, but we'll move on to that later on in the presentation. Really helpfully, we do now have an internationally accepted definition of social prescribing that is shared around the world, which helps us talking in common terms. And this was published about 2 years ago now. And what that says is social prescribing is a means for trusted individuals in clinical and community settings to identify that a person has non-medical, health-related needs and to subsequently connect them to non-clinical support and services within the community. So it's connecting people to their communities by co-producing what they call a social prescription, which is a non-medical prescription to improve health and well-being and strengthen community connections. So hopefully already there you can see how that could be so beneficial in terms of addressing loneliness. Just a little bit about my background before I move on and why I'm kind of talking to you today. So I've been researching how voluntary and community organisations support health and well-being since around 2008. And my focus is very much on understanding the value and impact of that work and then providing some critical analysis in relation to policy. That's led me to do lots of research around social prescribing. So back in 2013, I commenced a long-term evaluation of the Rotherham Social Prescribing Service that ran for 10 years and was really influential in policy terms. But I've also done work in Doncaster, Bradford, and Essex, and more recently I've been involved in leading national social prescribing research and evaluation projects, including around green social prescribing, active travel, and this idea of community-led social prescribing, which I'm going to come on to a little bit later. I'm really interested in how we can use social prescribing as an example of how voluntary and community organisations can be better integrated within health systems. Findings that we've been involved in have helped inform NHS policy, not as much as I'd like, in terms of the way the policy direction is going. And that's because we take a critical standpoint and like to think about how social prescribing can be done better. And sometimes within policy circles, there's not always that warm reception to some of those critiques, although it's improving, I have to say. So I guess the start point here is that there is really strong evidence that shows that social prescribing can help address loneliness. And I've highlighted 6 different studies that bring that to light. These were really helpfully identified by the National Academy for Social Prescribing in their recent newsletter. So, which is a really good source of wider evidence around social prescribing. So this study identified 11 intervention types addressing social isolation and loneliness linked to social prescribing in diabetes, and they saw how it could increase social interactions, provide support, promote mental health, mental and physical well-being, and support home and community care. And they found that group-based social activities, educational support groups, and recreational activities and training were the most effective. But there were a range of different interventions that were effective at addressing isolation and loneliness. This study discussed social prescribing in the context of it being a holistic health paradigm linking nature and community in this context. But they also identified a tension between some of the top-down processes that I mentioned earlier and the preference for more participatory approaches. But they identified really strong professional endorsement within the health system of nature-based social prescriptions. So that was really positive. And generally, professionals endorse social prescribing as a promising approach to tackling loneliness. But they also highlighted that programs really need to kind of think about how do you tackle those structural inequalities and adopt participatory governance as a way of addressing loneliness more systematically. This study identified 9 different positive outcomes related to loneliness and social prescribing, including reductions in GP, accident, emergency, and social worker and outpatient appointments. Really important in the context of the health service, but also that belonging to a group really does help reduce loneliness, and that links into healthcare utilization. And overall, social prescribing is a helpful tool to address loneliness. But they also highlighted some challenges around the evidence variability, which means it's difficult to draw conclusions on how impactful it is, and suggested that more research was needed. This study is really interesting because it was a natural experiment across more than 600 older individuals during COVID. And they're able to model the differences in health outcomes of participants who had access to community groups and those without access. And those who had access to community groups were more than 2.5 times less likely to suffer from loneliness, suggesting a really positive effect alongside lower incidences of cardiovascular and cognitive health decline. This study was another synthesis of evidence, and it looked at people who participated specifically in any social prescribing intervention aimed at loneliness or isolation. And they identified 3 themes. The first one being the impact on well-being. The second, the importance of the people's desire to connect with others. But they also identified some potential drawbacks of social prescribing, although they also highlighted there are more benefits than drawbacks. And again, they pointed to the need for more evidence about the mechanisms and effectiveness. This final study that I wanted to highlight was another mixed method study looking at the impact of support on loneliness and to look at barriers and facilitators. And they again found that the majority of people felt less lonely after receiving support, and again found wider benefits around well-being, increased confidence, greater sense of purpose. And skilled link workers were really important in relation to tailoring people's support needs, but they also identified challenges around volunteers, some people's needs in relation to signposting, and also being able to have a longer term sustained impact on, on loneliness. So in summary, we can see there's really strong academic evidence out there that shows that social prescribing can reduce loneliness. And it does this by connecting people to community activities, including things in nature and art, befriending, and that boosts well-being, mental health, and social ties. The studies show significant drops in loneliness scores, some of those kind of measures that we all know, and increased life purpose and satisfaction once someone's been referred. But whilst the evidence is strong, more research is needed, specifically around specific groups like children and young people, and we need to do more to understand the longer-term sustainability and effectiveness. My own research shows that we also need to pay more attention to the community aspects of social prescribing, and that's what I want to move into in the second half of this presentation. Because I want to argue whether or not social prescribing has lost touch with its community origins, and suggest that that might be quite problematic given where we are now. So thinking about some of those community perspectives on social prescribing, I think what does come out really strongly through the research that's been done is that voluntary sector and communities are the poor relation of social prescribing research. There's loads of research on social prescribing, not very much on the role of the voluntary sector and communities. Most studies have a kind of a clinical or health system lens. And that kind of reflects the wider policy environment around social prescribing, which is becoming more and more top-down and health system centric, which I think is problematic from a loneliness perspective. So we see concerns around community organisations' capacity to respond to increases in demand and the absence of any real financial infrastructural resource and strategic planning in relation to how we involve communities in social prescribing systems. Funding is really important, but we find that funding for community-based activities is piecemeal. It rarely covers the full costs of what's needed, and it's not sufficiently responsive to the increases in demand and complexity that people are seeing on the ground in relation to health and well-being. So that leads to frustrations that the health system has focused on funding these link worker roles at the expense of community-based activities in the erroneous belief that these are provided for free. So if we haven't got activities out there for people to address loneliness, social prescribing isn't gonna work. And we find that community organisations find themselves in a catch-22 situation where the health system is reliant on their close list of people, local people, and the types of activities they provide. Yet the system is also unwilling or unable to resource those activities sustainably. So if we haven't got the activities, we can't signpost people to them. So that's led us to think about whether or not there's potential to recenter social prescribing around community needs, assets, and resources. And we conducted a study specifically focused on this, a national study. And we talk about this idea of community-led social prescribing, but we want to be really clear that what we're not advocating for here is a new model of social prescribing. We've got enough models of social prescribing, we've got them coming out of our ears. What we want to do is think about how we can reframe social prescribing as a bottom-up, community-based health approach to health creation as it was originally intended, because that's the way that it's going to do the work, the systemic work that's needed around isolation and loneliness, for example. So we developed a working definition of community-led social prescribing and refined it in response to the research that we did. And that talks about community involvement or leadership of social prescribing being where residents have been able to influence or take control in the lead the design, delivery, and evaluation of a local social prescribing program based on what local people need and the solutions that exist on the ground. So very much putting social prescribing back into the hands of local people. This was intended to be a start point rather than an end point, to aid discussion amongst and between policymakers, practitioners, and researchers to help move things forward. We published this report about a year ago, and we are seeing now more and more discussion of the need to involve communities better in social prescribing. So just going over some of the key findings in that research, so you can see what we're picking up from communities and how that links to loneliness. So on the ground, we found really strong awareness of the health and well-being needs, including kind of loneliness being a really key issue, and community organisations being able to frame the benefits of those activities in relation to how you meet those needs. So we saw them doing things like setting up new groups and activities in the communities to plug gaps, bringing people together, connecting them, addressing loneliness, as we referred to earlier. then trying to sell those activities into the health system to get them funded and sustainable, but having a lot of challenges with that. They were receiving referrals from link workers, but that wasn't always, it was quite lumpy. They're also running pilot programs and trying to run their own social prescribing projects alongside the more top-down system. Not all areas are involved in complex commissioning arrangements and conversations with the health partners, and they are finding multiple barriers to entry. So challenges to get those community-based social connection interventions funded. And we kind of came up with this matrix of different levels of community involvement, from kind of strategic involvement and high leadership on the one hand to low involvement and low leadership on the other. We identified some real benefits to community leadership and involvement if the right funding and support were available and at the right level. So there's flexible funding and commissioning to enable community involvement, and that sufficient time and space was given to build those trusting relationships between communities and the health system. The reality on the ground at the moment is a really, really mixed picture. We see real variation in link worker practice and expectations. The role and scope and the interpretation varies, and there's very limited national accountability and data tracking around how social prescribing is being delivered on the ground, and that means it leads to variable practice. There's also concerns around safety, capacity, and levels of need, and kind of like the resource constraints that these community organisations are working within. But if we get it right, we can see we found real benefits in relation to the community ownership, connection, knowledge, highlighting the important work that community groups can do for health systems, particularly in relation to connecting people and reducing loneliness. But at the moment, there's risks around the lack of meaningful neighbourhood involvement and underinvestment in services and communities. So some of the enablers of greater community involvement and leadership in social prescribing include having those established local relationships and knowledge, developing a shared language and commitment, having strategic partnerships on the ground that connect everybody, having long-term flexible funding that supports sustainability, being really focused on safety and safeguarding, particularly in the kind of the rising complexity around need, and finding ways to balance capacity within community organisations to support people to connect and stay less lonely, and the demand for the support. And often there's more demand than there is capacity, and that's a real challenge. So, because we are working with the National Academy for Social Prescribing and Local Trust on this research, we came up with some policy implications and recommendations around community involvement in social prescribing. And I think these are really important when we think about what role can policy play in helping the health system address loneliness. So we came up with this idea of kind of like community-led social prescribing systems on the ground in neighbourhoods. But we also recognise that in most places these are an ambition; they're not a reality. But we found that we think there's 4 key steps that are needed to enable social prescribing to be recentered around community assets and resources. And these will be familiar to lots of people because I think it translates into lots of work that happens on a community level. So the first one is around building relationships. We need to improve connections between key actors within social prescribing systems and people on the ground in communities who are doing the work to connect people and support people at a community level. We then need to think about how we establish trust between all of those individuals and recognise that we're starting from a really low base, particularly in some of the more deprived communities who feel really mistrustful of health services and any kind of formal support. So that's going to take time, and it's going to take honesty, and it's going to mean thinking about how do we address those power imbalances that exist. Once you've got the relationships and the trust, you can start working out what your ways of working might be. What are the referral pathways and feedback loops and governance models that you can put in place to make sure that those referrals from the health system to community organisations can be put in place, and we can start actually getting people through to those interventions that might help address loneliness in the longer term. And then finally, we need to invest sustainably and over a longer term. We need to invest in capacity for community development and community resources, but also to make sure that there's a broader range of activities available and those are sustainable so that people can have access to community connection wherever they live and whatever it is that matters to them. So it feels like we're approaching a tipping point. I've been saying this for a long time, but it still feels like we're approaching a tipping point where we might be able to get policy to think more intentionally about how we support communities. Things like the NHS plan, which is very community and prevention focused, give us some hope. Although at the moment it's not clear where the finances and the investment is going to come from. So we think there's need, in order for this tipping point to be realised, we need to see action and change at multiple levels. So at the national level, we need much stronger policy guidance and commitment to community investment so that local areas can do the work that many people know is needed. Regionally, and here I'm really talking about the integrated care boards and integrated care systems where a lot of these key decisions are made. We need to think about what are the new kind of shared investment models that we can develop to enable us to invest in community capacity to address health inequalities and the social determinants of health. At a local level, primary care networks and general practices, they need to realise that community development is in the interests of their patients. It supports them, it supports the health of their communities to have a really well-resourced, well-developed set of community interventions that you can support people to address loneliness and a wide range of other needs. And obviously, I would say this because I'm a researcher, but we think it's important that this is evidence informed. So we need to, any policy that's made needs to be based on learning and insights that are generated from the community up. I think too much of the decisions that are being made from the top down and are not taking into account experiences from communities on the ground. That is everything that I wanted to share with you today. I think hopefully there's going to be time at the end for questions and whatnot. If you're interested in this specific piece of report, then you can scan that QR code and download the report here. I suspect the slides will be shared afterwards, so I won't leave that slide on for too long. But if you have got your camera ready, you can quickly snap that before I stop sharing. Thanks. So back over to Andrea.
Brilliant. Thank you, Chris. That's such a comprehensive overview. So thanks so much for that. So we'll come to questions at the end. So yeah, get any questions you've got ready and we'll move on to Jessica's presentation now. Gaetano is going to share that. She spoke to him a bit earlier today.
Yeah, so I'm going to share a video. Andrea, if you wouldn't mind just sending me a message in the chat if it's all working and you can hear it and everything.
Good morning, everyone. This is a short session from me, Jessica. I work with Good Practice Mentors, and I know I've met some of you before. I just wanted to share some of the practical tips that we learned from the Aging Better process, which would help people in terms of social prescribing. So, for people who haven't met us before, Good Practice Mentors are based in a number of organisations around the country. There's just 4 or 5 of us. My colleague Joe's at Age UK in Camden. I work for Leeds Older Peoples Forum, and then Vicky and Jenny and our admin team are based at the South Yorkshire Housing Association. And we share different expertise across all sorts of different things. This information comes from, it's part of the legacy from the Aging Better programme, which was a 7-year test and learn programme funded by the National Lottery, based in 14 places across the UK, and they selected places in rural areas and urban areas, cities, smaller towns. So we've got lots of practical learning from organisations in all those places about what worked really well. So it's not just based in cities or just based in rural areas. It should be adaptable to where you are. So it is very learning, and we've got lots of other learning we can share with you if you want to follow up on this. And this is definitely a whistle-stop tour. So the Aging Better areas mostly use social prescribing through all sorts of different agencies. Some of them deliver things directly, so there are people like Age UK. Some of them work like us through lots of small local organisations, and lots of people had to go at using the social prescribing model. This was sort of 2017, 2018, when social prescribing was definitely in its infancy, and we learned some quite key things about making it work really well for people. So, first thing to say, and I think probably fairly obvious and probably something you're already doing. It kept coming back to working in a person-centered way. The only way you could get someone who'd become chronically social isolated and lonely to engage with other stuff was to build trust with them, work in that really person-centered way and find out what was driving them. If you can make it face-to-face, this was particularly key for older people and for people who had any sort of disability. You were giving them an extra barrier if you were expecting them to come to you. It helped to be able to swap clients around in your team if you could, but it was all about building trust, matching people to the right connection, getting to know the community, understanding that you might need to do things for people to help build that trust, thinking about the achievable steps that you could take and building on those, and then reviewing progress, and remembering as well, think if any of you are on time limited programs that you need to start with an eye to when you need to finish, and you need to be honest with people about that, because if you encourage people to trust you and then you in their eyes let them down by walking away at the end, or before they're in a better place, or when they don't feel things have changed that much for themselves, it can be really difficult for people. So I'm just going to look at some of these things in a slightly more detailed way, just to give you an idea. So yeah, working in a person-centered way, I said, it always circled back to this. It wasn't any use just suggesting that someone went to some sort of social activity. I guess it works occasionally if you've got someone who's new to an area and they are genuinely just looking for things they can go and do themselves. But on the whole, if somebody's been referred to you, or you found someone who you think needs help in this social prescribing way, they aren't going to be in a place where they could just get off to a group and sort themselves out. They wouldn't be with you if they were in that sort of place in their own heads. But that was what social prescribing was inclined to do in 2018. And then they wondered a lot about why it didn't seem to work very well. And this person-centered working means properly listening to what people actually want to achieve and finding out why. It's really finding out the hook from them that's going to link them to changes they might make in their lives. You have to try and be quite impartial. You might feel you can see things that would be approved for them, but you just trying to encourage them to do things that you think would be better isn't going to work on their motivation to change things themselves.
Tano, I think
someone who hasn't been, who isn't already known to services, who hasn't been engaging with services well, then it might well be easier for them to meet you somewhere in the local community, somewhere that feels more relaxed and informal, not in the doctor's surgery, not in an NHS building. And I think the other thing about going to somebody that I should have said, I had a colleague who was a social prescriber, worked as social prescribing with AGK, and she said that she could find out so much more about someone in 5 minutes in their front room, that, stuff that would take her a couple of phone calls. So even though it felt like she didn't have time to go and visit people, she actually didn't have time to not go and visit people, because she could find out so much more about them and how their life worked, and it was quicker to build trust as well. So if you can go to people, then please do. Yeah, you need to build that relationship, trust, to help you to identify real barriers and aspirations. We found, all the colleagues who worked in this sort of way found that quite often, because of the stigma that there is around loneliness, people tend to offer you socially acceptable excuses, reasons why they can't do things, and then you can spend ages working on the wrong barrier with them. So it's more socially acceptable to say you can't afford to do something than to say that you're frightened of going somewhere because you haven't been to a group for a long time. So you could spend ages trying to sort out bus passes or sort of financial support. And yes, that sometimes is a genuine reason why people can't do things. But you need to sort of be able to drill down to find out what it is that's really stopping them doing things, whether it's it's anxiety, whether it's you've not really worked out what it is that would motivate them to improve their lives. So there's all that sort of stuff around it. In terms of trust building as well, we found it was helpful. People were sometimes in small teams and they would swap clients around as well if they needed to sometimes, because it would become apparent that there was going to be someone on your team that would build a better bond with them more quickly, establish that trust and help them to take the next step. So again, I know that might not work for everyone, because if you're not part of a team, then you've just got you, haven't you? But if you can, it's worth thinking about occasionally. Then thinking about what you're prescribing to, I think if I had £1 for every time somebody asked me this question about how to find out about what's going on in the local area and build a database, then I'd be a richer or my charity, be a richer charity. Yeah, you need to match people to the right connection or the right group, and you need to keep trying this one. We had a lovely case study of an older gentleman who'd had a stroke, and he was matched with a befriender from the local Older Peoples organisation, and it took them between them ages to work out things that he really wanted to do. He wanted to be, I think, quite intellectually challenged. In the end, he and his befriender, he was happier to fund a taxi and get himself across the city to a different men's group, where he could play chess and he could do other things that he wanted to, rather than going to the local group. For some people, just going to something locally is more important, but you need to work on matching that for people. You do need to get to know your local community and the activities that are on offer, and you need to keep doing this because things change. Things change all the time. I imagine you know that from your own organisations. There isn't a magic solution to knowing what's happening locally. You just have to keep doing it. Keep looking for things, making sure things still exist. It's also really important, I think, to make sure that those activities actually do offer a welcome to people. It's something we discovered during the Aging Better programme, that some social groups are less welcoming than others. I imagine you've known these groups, you've met them, and if they're really not very welcoming and you refer someone to them or you take someone there and they have a terrible time, then you can lose their trust and it can be so much harder for them to try again. So I think it's worth you checking things out if you at all can. And again, if you're part of a team, if you can leave each other notes, make sure that you communicate about good places that are welcome. And then, if at all possible, take someone to a session the first time they go, or arrange for them to meet a buddy from that organisation before they go. It is incredibly hard stepping into a group of new people, into a new activity on your own. Imagine for most of you in the room, certainly for me, I'd definitely rather go to a new thing for the first time with a friend. I actually did go to a new thing for the first time in ages this spring. And I turned up at the group and I asked somebody if I could have a seat next to them because it was quite busy. And she told me no. And I didn't believe that actually. Oh, yeah, I've heard of it happening, but it's never happened to me before. And I nearly took the hump and went home, and then I thought, no, I'm a big grown up, I'll push on through this one. But if I'd been feeling more anxious, I would just have walked out to that point. So it does happen. So try to make sure that they're friendly places to take people and try to accompany them if you can. Yeah, then trying to sort of heading towards the end. Little things again that you can do if you're going to get someone out from behind their front door into the world outside. Sometimes you might need to build trust with them by making some little things happen. We found some of our social prescribers, they were working with the very frailest, and were thinking that what they were going to need to do was sort out make sure that they knew about activities that weren't local and maybe take someone along to them. Perhaps sort out a grab rail by the front door. What they found was there were lots more complications that were making people's lives really difficult. But they found that if they could help people by sorting stuff out, little things to start with, sorting out that a bin collection was happening properly, because it might be really difficult for them to do that online. So you might sort that out for somebody. You might work out that they need help making an appointment with the optician. Little things like that. If you can do some of those little things, it means they trust you, and then they're more likely to let you help them with psychologically difficult things, with all those things that are based around their anxieties, and the things that are stopping them going out that aren't just the practical stuff. And then think about breaking stuff down for people, starting with really achievable steps. So you might think that they would really love going to a social club or a lunch club, and there's some people they might enjoy meeting there, but they're probably not going to want to go straight from meeting nobody every week to being in a big group. So it might be those little steps. It might be you meeting them somewhere outside their own house. It might be you arranging a small group meeting. So there were lots of things that we did sort of just to ease people back. And then finally, last few things really, really important to review progress with people. We all forget how things have changed for ourselves, don't we? And it helps people if they can see how far they've come, and it helps to build confidence for them. You need to accept that success looks different for different people, and that for some people, they may not go any further than perhaps having some telephone befriending. But that's made enough of a difference to their lives to make them much happier. And then, as I mentioned right at the start, you do need to think about starting with that an eye to the finish. So if you've only got a limited amount of time to spend with someone, they need to know that at the beginning, and then you can plan for how far you can get with them. And then, I won't talk about these, but these are just some helpful top tips that might help you in terms of the service you're building. I know we haven't got very long here. And there's some, sorry, I had to put these slides together quite quickly, so I haven't taken some of the pictures out. Enjoy the pictures. Yeah, we can offer you lots more support and training on some of these issues if that would be helpful. So there's just some connections and ways to get in touch with us there. Thanks.
And I will share those links and connections after the meeting, and hopefully find a way to share a slightly better quality version of that video as well. Back to you, Andrea.
Yeah, thank you. Yeah, I must apologise, everyone. Jessica stood in at the last minute, so we had to quickly prepare the slides this morning and record it. So sorry we didn't manage to get the sound quality at the right level, but hopefully you got the general message. And I think clearly for me, sort of the similarities in what Jessica was talking about are kind of at a practical level, and what Chris was talking about from the evidence base. The things that emerged for me was really the importance of trust, that person-centered, flexible approach, and really centered in the community, which Chris is talking about, the need to return to as well. So I'd be happy, really pleased if anyone's got any questions for Chris, and if anyone's got any for Jessica as well, we'll send those on to her after. You can either put the questions in the chat, or if you want to put your hands up, please do so and I'll bring you in. Stephen.
Hi, Andrea. Thank you very much. Yeah, those were great presentations. The one thing I really took away from Jessica's is that insight to not sort of dealing too much with those red herring barriers, actually trying to identify what the sort of real barrier might be. But I just wanted to ask Chris about your research, and just sort of whether there were any insights across the life course. As we know, loneliness can happen to people at all ages and any age at different times in their lives. And I was thinking about those mechanisms for social prescribing enacting them, and whether you detected any sort of gaps for different age ranges or things like that, or whether, the social prescribing mechanisms are robust and developed enough now that they're looking at across the life course and across age cohorts in different ways.
Thanks, Steve. We didn't go into that level of detail, but what we do know from the wider evidence is that if you look at the kind of like who gets referred to social prescribing, it does tend to be old people who are older. People, it tends to be more women than men. And at the moment, the model is very much an adult model. And in the universal sense, there aren't as many examples of children and young people. And I think there's a real gap around children and young people and the types of activities they might want to access to address in terms of loneliness will be very different to a lot of the types of activities that might be an offer in your typical community centre. Because obviously, I guess the thing that's really affected young people is the reduction in youth services and youth clubs and things. And at the moment, there's not a lot of evidence that social prescribing has done much in that kind of infrastructural sense. There's some really good examples of link worker support for young people on CAMS waiting lists, for example, and whatnot. But I think I think the next step we need to go down is actually that intersection of the live course, and is social prescribing more effective for a particular type of person, a particular transition point or age group. So yeah, I guess it's where the evidence needs to go next, I think.
Thanks, Chris.
Great. And just a quick follow-up, Chris, on that. I'm guessing the same is true then of intergenerational kind of support as well, because, I think, yeah, we do need to look at all age groups, but that connection between age groups is obviously really important in terms of tackling loneliness as well.
Yeah, and I think one thing the health system still does, and I think, and it's really difficult to move out of this, is it puts people in boxes, and often those boxes are in relation to their age group or their condition, and then that makes intergenerational work kind of support much more difficult. And so I don't think at the moment the intergenerational lens has really been cast on any of this. So we don't really know what's going on. I suspect there's some really interesting examples of where it is happening organically, but we don't know enough about it for sure.
Thank you. Yeah, really interesting, and obviously an area to start thinking about more as well, and maybe getting that more on the policy agenda. Thank you. Kenneth.
Well, this is for Chris, and hello, Chris.
Right.
Having met you on Tuesday.
Yeah, small world.
Small world, yeah. Maidstone's got a population of about just under 180,000. We've got at least 25 community singing groups. The great majority of them will not be on Joy, and they will not have registered in a way that makes them readily accessible to social prescribers. And part of the reason is that the governance expectation is not very appropriate for small community choirs. It's bad enough getting anybody to serve on the committee, but if you go through all the governance requirements, nearly every policy and procedure needs a named person. So suddenly you've got 5 or 6 new tasks.
Mm.
And whilst the groups are perfectly capable of actually supporting people and want to do it, they are discouraged by if you like, a large organisation expectation in terms of governance. And that, I think, inhibits genuine community engagement.
I think it's a really interesting point, and I think, again, this is where variation in local practice and lack of clear guidance from the top is really unhelpful, because actually there's nothing in any of the social prescribing policy that says there needs to be any governance arrangements in place. So this, at a really basic level, this is just about connecting somebody to a singing group. There shouldn't be any requirements around governance. I think anyone who's putting those requirements in place has fundamentally misunderstood the whole point of social prescribing, which takes us back to and I suspect that's probably come from a GP practice or a primary care network that feels like it needs to have some kind of control over the community organisation it refers to in the way that
No.
it would have control over the drugs it prescribes, and that's not the intention.
Now, I can assure you, all of the databases that were set up in Kent had a pro forma, and that
Yeah,
pro forma required you to tick boxes on, equalities, GDPR,
yeah.
safeguarding,
But
health and safety.
that's somebody within the health system putting an unnecessary barrier in place. That barrier
Yeah,
is not necessary. That barrier has not been sent from the top down by NHS England. That's somebody overzealously interpreting what they need to have in place in order for social prescribing to happen, because it should be much more fluid and informal than that. And I think going, and which I guess goes to the other point around not being able to prescribe to something if it's not on a database. That shouldn't be a barrier to being prescribed. It should be the social prescriber should feel empowered to refer anybody to anything that they feel is appropriate in the community, whether or not that's on a database or not. Because for some people in some kind of with some certain, I guess, clinical needs and whatnot, then yeah, it's really important that we do have that governance and that safeguarding in place. But for somebody who just wants to go to a singing group, we don't need to be putting that barrier in place. And I just think it's a really good example of what I was talking about in terms of social prescribing has become too top down. It was never supposed to be top down. It was always bottom up. It was always community-led innovation. And the health system's got hold of it, put all of these kind of systems and processes around it that are not doing us any good at all.
good.
Thanks, Chris. I think just a quick question from me in relation to that. So, how much training and awareness and support is there for people in the health and social care system to know this? Because I'm guessing it's that they actually they lack awareness and understanding, so they're putting these measures in place as kind of a precaution, but
Yeah.
they don't actually know. I'm guessing that's the case, but is there much support?
There is training. There's a level 3 link worker qualification now, but none of it's mandatory. So you don't have to have done the training to be a link worker, and you don't have to. So it is a little bit like it's a little bit like the Wild West. So whilst I wouldn't advocate for it being completely unregulated, I think what's happened is, particularly where it's been, I guess, the health system has come in and taken leadership of it. They've created a lot of bureaucracy and governance and things around it that are unnecessary in most cases, particularly when we're talking about a universal model, which is meant to be for people with relatively low level needs that can be met in the community. When we start talking about clinical needs and clinical conditions, I think then we need to start thinking a bit more carefully around governance, but not in most cases.
Thank you. Thanks, Chris. So we've got another question from Paul. Paul, are you on the line to ask a question yourself? Paul can? Okay, maybe
Yeah,
I'm not sure.
hi.
Oh, great, brilliant, Paul.
No, I just wanted to pick up something I heard a while ago, Chris, and it relates to your thing about community owning social prescribing. And this guy who I think was from Torbay said the community has what it needs when it shares what it has, which is a great little soundbite. But how do you ensure that the communities are sharing? What are the things that happen in successful community-led social prescribing schemes?
I think a lot of this goes back down to good old-fashioned community development, and there's a little known requirement of NHS funded social prescribers, which is around proactive social prescribing, which essentially says it is part of the link worker role to engage in community development, to go out and understand what groups are out there. If the groups don't exist, find ways to support them to develop. So I think it's about on the ground having the mechanisms to have those relationships built. And I don't think that we have enough resources in that community development space to enable those relationships to be developed. So there's a lot of, I guess, lack of awareness on both sides around what exists. A lot of community organizations don't know that social prescribing exists, and a lot of the social prescribers don't have the time and they're not empowered to go out and do that work on the ground to see how they can support people more effectively. They're being judged on how many people they see rather than how effectively they're supporting their community. So the model is kind of got its got it wrong. In my opinion, I should say, and in the opinion of a lot of people in communities.
Thank you, Chris. We've got another question from Crawford.
Thank you. It's a question for Chris. I'm work with Glasgow Life, which looks after museums, sports centres and libraries on behalf of the City Council. So there's been a social prescribing model in place. For a couple of years, I worked on the development side of it. Increasingly in Glasgow, there's a focus on child poverty in terms of the main City Council issue. I wondered if you had come across any examples of family-based social prescribing. I ask that because there's a geographic focus within Glasgow around 10 ward areas, and it's thrown up this issue of, whilst the model already exists around an adult programme, it doesn't exist around youth, and it certainly doesn't exist around a family cohort.
Yeah, so it's a really good question. I forgot to say at the beginning, a lot of the research I've done, and a lot of what I'm saying is based on the English model, which is different to the Scottish model. And some of the engagement I've had with colleagues in Scotland suggests that I think potentially the Scottish model is a little bit more community-led, which is really positive. And there's still challenges with it. So I just wanted to say that it's a classic mistake that English academics make, is that we just assume everyone knows we're talking about England when the UK is very different. On the family model, yeah, that's a really interesting question. And so in Sheffield, where I'm based, the Children's Hospital have recently developed a family social prescribing model. So what they've done is they've identified that they have families who are in regular contact with the hospital, the Children's Hospital, what you might call frequent flyers or frequent attenders, use A&E a lot, use blue light services, are often on the kind of the margins of the children in need register with social care and things like that. So they have put a family model in place, and they're delivering that through some of our community anchor organisations. It's still really early days, but some of the initial kind of feedback coming out of that is that it's proving really, really effective at identifying the complexity and variation of needs within specific families, and then helping them put support together that cuts across education, health, social care, to hopefully put them on a better trajectory. But it's very resource intensive, and that's just a 2-year pilot that the Children's Hospital have funded in Sheffield because they're quite progressive. And there's other pockets. I think there's another one in the northeast, but there's not very many of those about at the moment. But I think capturing the learning and showing that will be really important.
Thank you, Chris. And we've got another comment in the chat, which is not a question, but from Shona Kinnock, who's saying that she's a community social prescriber herself, and that they work in partnership with lots of community and voluntary groups and statutory groups across the city, and really just demonstrating that, that seems to be working well, and there's lots of outreach with food banks, libraries, NHS events, etc. And I suppose, Chris, I've not done lots of research on social prescribing, more on the loneliness side. But from my understanding, it's kind of part of the problem here is that the fact that it does work well in some areas and not in others, and there's no consistency in terms of that. Is that something that you've come across as well in your work?
Yeah, I think absolutely. I think generally speaking, we find that community link workers and community connectors, they know what they need to do. They know that they need to go out there and build those links with lots of partners. Some of them are empowered to do it by whoever their employer is, and some of them aren't. And I think it's that's where the difference comes in. And a lot of it's about whether or not, particularly when they're employed by a GP practice or a primary care network, essentially, is that GP practice working through a community lens, or is it working through a clinical lens? And what's the kind of the paradigm that they approach all of their practice, and then that follows through into how they develop and implement social prescribing. And there just isn't enough top-down guidance. There isn't enough of a vision from the government about this is how we want it to happen in practice. And there's no holding of account. So GPs are given the money for the link workers, but they're not really held to account in terms of how they then implement that. There's all sorts of political reasons I could go into why that's the case, but
Yeah, I'm sure I'll put maybe another webinar on that one. Any more questions from anybody? Feel free to stick your hand up and ask Chris, or if you've got any questions for Jess. Can't see. I'm just scrolling through my screen. Apologies in case somebody's got their hands up that I can't see. I've just got one last question then, Chris. Kenneth, go for
Yeah,
it.
it's just going back to what I said before. Community choirs will be in the evening. And, we've heard a lot about, holding hands. Do realistically we expect that social link workers are actually going to be doing that during the evening?
yeah, it's a really good. One of the things that we've seen that can make that happen is not necessarily expecting. You can't expect the link worker to take every patient, every patient to every activity. So developing befriending models, for example, where somebody you might identify somebody within the choir who is linked into the link worker, and that person then becomes the buddy who takes them to the supports them to access the activity in the evening. Those kind of models are, I think, where we need to go because we haven't got the resources to support everybody with a paid worker to access the intervention.
Okay,
Yeah.
good.
And of course, we know, Kenneth, that if we're thinking about when people are most likely to be lonely, it can be at weekends, evenings, so weekends and evenings and bank holiday times, for example, when, some of those link workers might not be working, as you say. So how do we create sustainable models so people get the support to get there, but then that can be sustained long term, I think is really crucial. Any more questions? Okay, I'll just ask my last one then, Chris. Just thinking, so when I'm thinking about loneliness, I'm not just looking at the way people connect with other people, but how they connect, maybe create that meaningful relationship with themselves and also with places and spaces and that sense of belonging. And I know you mentioned about the importance of community. I'm just wondering if you've come across much in terms of social prescribing to services that link people to their communities and to those spaces, as opposed to just the kind of connecting to others through social groups or through befriending services.
It's a really good question. I guess it doesn't necessarily have to. I think probably a lot of it is to groups, but it doesn't necessarily have to be to groups. So there's an ethos at the heart of social prescribing is about it's about finding what matters to you. So I think it's that meaningful conversation between the individual and the link worker about what matters to them that then results in what it is that they end up doing. So I think in theory, those what matters to you conversations could lead to those types of opportunities. And I think a lot of people end up volunteering, for example, and I guess becoming more engaged within their place. But I don't think it's not necessarily viewed through that place lens, and that kind of like that is very much it's quite instrumental in terms of linking people, linking things rather than I guess the more a kind of a place level, if that makes sense.
Yeah. So I suppose again, it's part of this training and awareness for the link workers on what social connection means. And yeah,
Exactly.
brilliant. Okay, excellent. We've come to the end of our time. So thank you ever so much, everybody. Gaetano will send over the presentations and any links to reports and things. Yeah, and we had actually had a webinar on Monday this week on volunteering and loneliness as well. So if anyone is interested in that, you can listen to that as well, because I think it connects quite well with what we've been talking about today. Thank you ever so much.
Thanks. Bye.
Thanks.